Succinctly, what I teach to the students is at diagnosis there's about 1 kilogram of tumour. Now in a leukemia it's disseminated, but what we call morphological complete remission is just less than 5% blasts in a regenerating bone marrow. So if you say 5% is a 2 log reduction from 100%, you don't know whether you've got 10 to the 10 million cells, or a kilo corresponding to about 10 to the 12 cancer cells, or whether you've got none. So historically, the game in MRD was to be as sensitive as possible and to continually monitor patients. But with time, because MRD became fashionable about 20 to 30 years ago, with time it's much more, we need to provide relevant information at the time when therapeutic decisions are made. So, schematically or in a somewhat, sensationalist context, there's not that much point in spoiling the last 3 months of a patient's complete remission by announcing that they're going to relapse if you don't have something constructive to suggest. So that very much depends on the kinetics of relapse. If you've got a rapid kinetics, you'd have to do MRD follow-up every 2 weeks, and nobody wants a bone marrow every 2 weeks. Whereas in non-acute leukemic disorders, you can have kinetics of relapse that can be measured over months or even years in some indolent disorders. So there's a whole concept for preemptive therapy. But to come back to your initial question, of course it's got to be measurable. And certainly my standpoint is I'd prefer something that's slightly less sensitive but robust than something that's very sensitive but not reproducible. And the final thing I would say is, for DNA diagnostics, you can't have something that's more sensitive than the detection of 1 copy. And in 100 nanograms of DNA, you've got 15,000 cells. So if you're only going to analyze 100 nanograms of DNA, you can't promise to detect 1 cancer cell in a million, 1 in a million, unless you're working at the RNA level, because the cells transcribe at different rates. And that's one of the reasons we like DNA diagnostics, because it's easier to equate response between patients.